and especially which may be palpable or non-palpable erythema over the bridge of the nose and the middle prominences, then this may be seen in not only one rheumatic disease, but in some other rheumatic diseases also. And not only in rheumatic diseases, but in other rheumatological diseases like seborrheic eczema, like rosacea. So just seeing this erythema of the face would not help us to diagnose a rheumatic disease unless we are aware of certain other features, characteristics of this facial erythema, especially the areas of the body. Whether it is only involving the bridge of nose and the malar prominences, or it is also involving the nasolabial folds, or the eyelids, or even the forehead, and the other body areas. And if there is any involvement of scalp, also or not, then just redness is not important. We must be analyzing the hue of the color, whether this is just pink or reddish or is violaceous. Then we will ask the patient about the history of itching, if it is mild, absent or severe. So these factors will help us in diagnosing. The malar rash which is seen in SLE is present in 50% of cases at time of diagnosis of SLE. So this is quite significant. Then another significance of this malar rashes, it precedes systemic flares, weeks or months. So if patient is on treatment, and the malar rash has shown initial improvement, and then there is worsening of this malar rash, this may indicate that soon the patient will develop systemic manifestations also. The important features of malar rash in SLE is that it would not involve the nasolabial folds. The hue is reddish, it's not violaceous, and normally it would not involve the eyelids and the foreheads. So this is typical butterfly rash seen in SLE. Now, in contrast to SLE, in the rheumatomyositis, it is centrofacial rash, where it is more confused with rosacea, which is also centrofacial. But in rosacea, we also see pustules, which is not seen in the rheumatomyositis. Then such a rash is also seen in seborrheic eczema. But in seborrheic eczema, we see on top of this erythema lot of greasy yellowish clustering and scaling, not only on the centrofacial regions and in the nasolabial folds, but also on the scalp, around the ears, front of chest, and the upper back. Then the violaceous erythema is significant. Violaceous color because of dilation of the superficial dermal vessels in the rheumatomyositis. It also indicates disease activity. The more the violaceous erythema is there, this means disease activity is more. The nasolabial fold and periorbital regions are involved. It also involves the forehead and the scalp also. And there is pruritus, that is itching in cases of this erythema and rheumatomyositis as compared to SLE. Then a patient who presents with these types of erythematous hyperpigmented plaques with surrounding hyperpigmented border and mild staining and atrophy in the center, over the face, over the trunk. So this is important. This mimics some other dermatological diseases like vitiligo because its color is whitish. But in vitiligo there is never atrophy and there is never staining in vitiligo. Then it also mimics psoriasis. But in psoriasis also there is no atrophy and the border is not hyperpigmented in psoriasis. But in this case, if you look carefully with a magnifying glass especially, you would see the central area is hypopigmented or depigmented with telangiectasias and scaling and follicle plugging, and the border is hyperpigmented. This may be seen over the scalp, over the face, over the trunk, and over the wings also. So this is known as discoid rash, that is discoid lupus erythematosus. So seeing and recognizing these types of lesions can help us to assess their underlying disease and its prognosis, because this is seen in only in 5 to 10% of such cases they were persevere. And then majority of time of diagnosis are within 5 years. So the prognosis is good if there is extensive lesion of DNA, it's not likely that this will remain as a localized type of discoid localized LD, and only 5 to 10% cases will develop florid SLE. Now, annular plaques, that is ring-like lesions, with the center is relatively clear and the border is more erythematous. Such lesions are known as annular lesions, and the patients may present with these lesions of the face, over the upper trunk, front and back, and the shoulders, along with joint pains, and then this mimics so many other dermatoses, like because ring-like lesions mimics tinea corporis, fungal infections, but it also mimics psoriasis, it also mimics eczema. But there is important differences of these lesions from others, and this may turn out to be a case of subacute lupus erythematosus. So if a patient presents with annular lesions, never think that this is only tinea, eczema or psoriasis, but it may be a case of subacute ND. Then a patient presents with, this patient presented to us in the OPD with extensive redness, gross edema of periorbital regions, the eyes were closed, and we initially thought this is just contact allergy contact eczema or photodermatitis. But the other features, the other signs helped us to reach the diagnosis. So vivacious color of the redness and edema of periorbital region is important sign. Like this child, a girl presented with this only vivacious erythema over the eyelid with mild edema. Then we get a clue, we got a clue that we must look into other signs of the disease. And this is an important sign the patient turned out to be a case of rheumatomyositis, which is a highly characteristic sign, the heliotrope rash. Is an important, highly characteristic sign, and this indicates the activity of disease. So it means that rheumatological signs not only are helpful in diagnosing, but in predicting the disease activity. And in our races, dark races, sometimes this vivacious erythema is subtle and overlooked, especially in darker skin types. So we clinicians must pay attention to the periorbital region, especially for this vivacious color and edema. The examination of ears may reveal petulous follicle opening and keratin plugging. Never take it lightly, because this is a highly specific sign of discoid lupus erythematosus. A patient presented with these types of vivacious erythematous papules with the dorsal aspect of metacarpal frontal and interfrontal joints, along with other manifestations, then this seems that it may be psoriasis, or these are reddish and mildly scaly in the gross aspect of the hands. This may mimic some other diseases like eczema. But the violaceous color, sometimes these papules and plaques have smooth surface, but at times these become atrophied. These also develop ulcerations. And this is significant because these are bottom papules. And this is pathognomonic of dermatomyositis in more than 80% of cases. So we must look for these bottom papules in patients with joint pain and systemic manifestations. These violaceous erythematous patches, which are really defined in bilateral over the knees, over the elbows. If a patient is seen with these things, again, this is known as Bottom sign, which is again pathognomonic of dermatomyositis. It is symmetrical, which is well defined. It also may display atrophy in papuloderma, especially juvenile dermatomyositis. This B sign, which is erythematous and defined telangiectatic patch, or the anterior neck and the chest, and we can see the hypo and hypopigmentation later on in this region. This is seen both in lupus erythematosus, SLE, and dermatomyositis. Shaw sign is another important sign in dermatomyositis, which is vertical violaceous erythema, or the upper bag in the nape of the neck. Foster sign, symmetrical violaceous erythema on the lateral hip and the thighs, and knees are extremely itchy. Papuloderma, which is basically when we see papuloderma in the skin, this is constellation of reticulate hyperpigmentation, hypopigmentation, atrophy, telangiectasias. This may be seen over the neck, chest, and later on it may be widespread all over the body. This is seen both in lupus erythematosus and dermatomyositis, but mostly we have seen cases of dermatomyositis presenting to dermatologists, presenting to us only with widespread papuloderma involving the whole body. So papuloderma may be the initial presentation of the patient with dermatomyositis. Although there are many other differentials of this papuloderma, like cutaneous B-cell lymphoma, radiodermatitis, LEP even, but considering the whole scenario of the patient, it can be the initial manifestation of dermatomyositis. The hands, where the skin is taut, thick, shining and hide-bound skin with contractures of the fingers, that is fibrosis. This is progressive skin fibrosis in scleroderma is associated with worsening lung function. So we must evaluate the patient's common functions in patients with scleroderma. Telangiectasias, telangiectasias, this is an easily accessible biomarker of systemic or microvascular disease. So you see a patient with scleroderma and extensive telangiectasias, you must evaluate for other systemic microvascular disease injury. It is strongly associated with pulmonary vascular disease, pulmonary arterial hypertension, and systemic sclerosis. So this sign alone predicts the severity of underlying systemic problems in patients with scleroderma. Now these cases we commonly see in our OPDs where there is salt and pepper pigmentation. Sometimes this may be the initial presentation of systemic sclerosis. This type of hypopigmentation over the face, over body, may be the initial presentation with mild fibrosis, with mild skin tightening. So never take it lightly. Then here there is persistent pruritus due to fibrosis. There is contractures of the fingers. microstomia, mask-like face, loss of wrinkling, difficulty in inversion of the eyelids if you try, classical signs of scleroderma on the face. Now this patient, as we see Sgt. Pepper, hypopigmentation extensively out of the body. This patient presented to us basically not with Raynaud's, not with skin thickening, but basically with this disfiguring pigmentary changes. And on further examination and investigations, turned out to be a case of systemic sclerosis. So this is the important, maybe the initial manifestation of systemic sclerosis. Raynaud's, we are now seeing in maybe the mostly initial presentation of systemic sclerosis. Ulceration over nipples are seen not only in scleroderma but also in dermatomyositis and SLE, but more commonly in systemic sclerosis. Loss of tissues, gangrene, again manifestation of scleroderma. Now, patients will present to us mostly in the rheumatological OPDs with these types of shine, indurated, hypopigmented, sometimes atrophic plaques over the trunk. These patients sometimes have other systemic manifestations also. But this is a case of localized scleroderma. Patients presented to us with sunken cheeks. And on taking history, it was found that initially the patients were painful, tender, nodules and plaques over the cheeks. But later on, led to atrophy and loss of the fat, and patients presented with sunken cheeks. Lupus paniculatus, cheeks is an important site of lupus paniculatus. Along with these lesions, we have seen over the thighs. So cheeks, thighs, and upper arms. If we see the indurated nodules and along with the sunken areas, it is an important sign of lupus paniculatus. Because in simple lipodystrophy, we don't see the nodules, we don't see the indurations. And sometimes on top of these lesions, we also see the squared like lesions also. So, sunken areas over the cheeks, upper arms, thighs, long history of painful nodules, or DLE-like lesions over these areas, important manifestation of lupus paniculatus. This also occurs in 1 to 3% of patients of SLE, but mostly 70% of patients of DLE. Erythema nodosa, we all know, painful, tender nodules over the shins. This is seen in so many diseases, like in sarcoidosis, in tuberculosis, but also seen in connective tissue diseases, like SLE, dermatomyositis. Rheumatoid nodules, periauricular nodules. Rheumatoid nodules is a sort of paniculitis basically. This is the most common extra-articular manifestation of rheumatoid arthritis in 20% of the patients. And systemic iron medications are not a proven therapy. Paradoxically, may induce or exacerbate periauricular nodules. Calcinosis, hard, yellowish nodules over the fingers. These are especially over the trauma-prone sites. They rupture through the skin based to chalky white material, associated with delay in treatment and associated with increased disease activity and duration. So calcinosis, if there is a delay in treatment, then more chances of calcinosis, especially in patients with scleroderma and in patients with dermatomyositis, and leads to chronic core ulcers. large ulcers, violaceous borders, undermining of the borders. Patient presents with these types of extensive ulcers, which is pyoderma gangrenosum. Although this is a misnomer, it is neither infectious nor intravenous. This is non-infectious ulceration. This is important manifestation of rheumatoid arthritis, important manifestation of osteoarthritis, and also seen in SLE and dermatomyositis. So, we must be able to recognize, and when a patient presents to us with these lesions, it is important to investigate this patient for rheumatic diseases besides so many other underlying conditions like rheumatological malignancies, solid malignancies, hepatitis B and hepatitis C. But we must be able to recognize the characteristic features so that we can easily diagnose clinically as these ulcers in pyoderma gangrenosum, because the border is violaceous and undermining of the margins, the culture would be negative, gram staining would be negative, but this is non-infectious. Important differential in this pyoderma gangrenosum is paniculitis or vasculitis. But in paniculitis, we would get nodules underlying, but pyoderma gangrenosum usually starts with initially vesicles, pustules, or a mild papule, and then it leads to extensive ulcerations like this. This is an important and common manifestations. Patient presenting both to rheumatologists and rheumatologists. Patients will present to us with palpable purpura, non-palpable purpura, hemorrhagic vesicles, necrosis, and ulcerations, especially over the legs. So this combination of the cutaneous lesions give us an opportunity to diagnose that this is a case of vasculitis. But important question arises whether this is small vessel vasculitis or medium vessel vasculitis or a combination of small and medium vessel vasculitis. And how important, there are two important clinical tests to do whenever the patient presents with these types of lesions. One is to always palpate the lesions. This is very important. Because if the purpura, that is non-branchable purpura, is palpable, which is known as palpable purpura, this is a sign of vasculitis. Or this is due to inflammatory infiltrate, which involves the capillaries, the post-capillary venues, and presents to us as a palpable lesions. But if the purpura is not palpable, it's just flat, we are unable to feel it. So always try to feel and palpate with your palm these lesions. Then it may be due to clotting factors, due to coagulation factors, and so many other diseases. So important clinical, I think, method to diagnose whether this is vasculitis or a purpura due to coagulation defects or clotting factors is to palpate the lesions. So this is small vessel vasculitis. But if we get the painful nodules and which are straight, along with this there is rheumatic traction over the legs and the feet, this is different. So this is medium vessel vasculitis. So medium vessel vasculitis would show us like cutaneous polyarthritis nodosa is medium vessel vasculitis. So sometimes we get a combination of both medium vessel and small vessel if we get both nodules and palpable purpura. Then orogenital ectosis, which may be large, few or multiple, along with genital ectus ulcers, is an important manifestation of gaseous disease joints. Now this type of disease is also a common presentation that we see in OPDs, and also I think rheumatologists will be seeing these things, where there are painful stellate punched out ulcers with ivory-white scars and terrorism areas. So this is atrophy blanch, and there is a need to investigate for vascular diseases besides venous insufficiency, besides triglobulinias, and so this type of presentations, patient would complain of severe pain, and on palpation you would feel that this is tenderness, punched out ulcers, ivory-white scars, and conjunctivitis of the legs and the motor reticular branchial vascular pattern. This is known as libido reticularis. This is seen in connective tissue diseases. Can be benign or can lead to an underlying disease. So, if you see such pattern, there is need to investigate for connective tissue diseases. When a patient presents to us with thick hyperkeratotic lymph-like plaques over palms and soles and joint pains, this is a case of reactive arthritis, that is Ritter's disease. Now this patient presented to us with short history of fever, joint pains, and painful tender ligaments over the hands and face for the last 7 days. So, pseudovascularization of the plaques. So this turned out to be a case of Sweet syndrome. Alopecia is seen in so many rheumatic diseases. If it is scarring with DNA-like lesion, this is squamous lupus erythematosus. This is lupus hair. Scarring alopecia over the scalp in DNA, and lupus hair in SLE, which are seen during flares in the short, sparse, lustreless, fragile, and less pigmented hair. Red and white patches on the scalp is an important feature of dermatomyositis along with alopecia. Psoriasis, well-defined erythematous plaques with silvery stage of the scalp. DLE-like lesion over the lower lip, manifestation of DLE. And orogenital ulcerations, especially on the palate, is an important feature of SLE. A white palatal patch is an ominous sign of dermatomyositis. This indicates you must look for the underlying pregnancy. Pore spitting and subungular hyperkeratosis is seen in psoriasis. Oil drop sign, that is yellowish waxy patch, is seen in psoriasis. Nail fold changes, radial cuticle, dilated nail fold capillaries, dermatomyositis and scleroderma. So, then the take-home message is knowledge and skills